All right, I think we'll get started. This has been so much fun. I'm so happy I was able to attend this year, and I want to sincerely thank the IgG4ward Foundation for hosting this, and all the patients and caregivers and industry partners and everyone who made the effort to come. Less sincerely, I want to thank John and Arzu for giving me this very simple topic to close things out, and only 20 minutes to do it. So we'll jump right in. These are my disclosures. As many people have mentioned, and as you all know, this disease presents heterogeneously, meaning there's a large spectrum of organ manifestations and the way in which it affects an individual patient. So the best analogy I could come up with for this topic is from sports. And if you ask a referee, how do I know if there's a foul or penalty in sports? The answer would be, well, it depends. If you're refereeing basketball, this would definitely be a foul. But if you're refereeing football, it's just part of the game. In soccer, if you are on the field and you touch the ball with your hand, of course, that's a penalty. But in baseball or softball, it's expected. So there's not one rule that applies to every sport that can tell you if there's a foul. And similarly, in IgG4 related disease, as we all know, it can affect the body so differently. There isn't going to be one specific test that can tell us for every patient in every situation if the disease is active. So this is a patient with predominantly lacrimal and salivary gland disease, a patient with Pancreas disease, and we often see both of those together as well. A patient with predominantly disease affecting the aorta, large blood vessel, kidneys and retroperitoneal disease, and then of course we all have patients who have the disease throughout the body. And there are some common threads in terms of how we might determine disease activity, but also specific different tests that we might do for these. There are some general principles. The first is that it really requires a comprehensive evaluation, and it really starts with that conversation with the doctor, because the symptoms and the things that you tell the doctor will really direct the focus of all of the remaining items up here, which include the exam, imaging, blood tests, and biopsies. So, if you tell the doctor that you're having weight loss and worsening diabetes, of course, they're going to be thinking more about the pancreas. They're not going to get a brain MRI probably, but if you're talking about headaches and dizziness and things like that, it will direct the workup in a different direction. This is my only slide with a lot of text, but I think these are important points. We've talked about serum IgG4. I'm going to show some examples of how we can use that. It generally is a good biomarker. John mentioned some of these other labs that we follow in the Q&A, things like complement and IgE, sometimes the eosinophils and the blood count. The important thing to remember is this is a disease that causes enlargement of organs, masses, or thickening of thin-walled structures or tubular structures in virtually every case. And so what we really want to assess is that feature changing? Is that getting worse? Is it active? And we often need imaging or exam to do that. And patients frequently want to know, well, what is the exact imaging study and how often? And there isn't one answer for that either. It really depends. If a patient is 35 and I want to assess their aorta, I would probably try to do MRIs to prevent them from 50 years of radiation exposure from CTs. If a patient's over 65, the amount of radiation that will accumulate for the rest of their life, it likely won't affect them unless this anti-aging phenomenon kicks in and we all live to 150. But in general, after 65, CTs are not so much of an issue. The disease stage also matters. If I've had a patient who has been treated and seems to flare every 2 to 3 years, I'm not going to be monitoring them with imaging very intensely in that first year and a half, but as I get closer to the time they're sort of in that risk period, we might be doing imaging every 6 months. So there's a lot of nuance to answering that question. And then in general, as a principle, we really don't need to repeat biopsies of the same organ if we think it's active. But if a new area develops in the midst of a flare, sometimes we do need to repeat a biopsy of that particular manifestation to make sure it's not cancer or something else. And so this is just sort of an overview of a lot of what I said. These are sort of I would say, the common thread of tests that apply to most patients. Just a quick word about the imaging studies, because there's some nuance here too that matters. We often get CTs of the chest, abdomen, pelvis. We're also learning now that the blood vessels around the heart can be involved. And that requires a very specific test. The second one there, the gated study. The way that CTs work is it sort of takes what we call slices. It takes pictures as it moves down. A normal CT doesn't care about how the heart's beating, and so as it's taking those slices, the heart's beating, and at the end, the heart looks very blurry. And the point of that study is typically not to look at the heart. But a gated study takes the picture every time the heart is in the exact point of the cardiac cycle, what we call mid-diastole, when it's relaxed and not contracting, not moving. And it does that at each slice at the exact moment. So the heart comes out very clear, and you can see the arteries around the heart, which can matter for certain patients. Most of the other imaging studies, CT, neck, MRI orbits, typically require contrast. And then a PET scan, for those of you who haven't had it, you get an infusion of a radio-labeled form of glucose or sugar. And then parts of the body that are metabolically active will consume that sugar and then light up on the scan. So of course the brain is always very active. That will always light up. Your heart generally will always light up unless you follow a specific diet protocol. And then besides those two organs, other areas that light up tend to be metabolically active. It could be cancer, it could be an infection, or it could be inflammation from a disease like this. Other tests that sometimes are used are procedures like ERCPs, where they do an endoscopy and actually cannulate the bile ducts and can shoot dye up there to see if they're patent or open. Bronchoscopies into the lungs, sometimes to do biopsies. ENT endoscopies to look up in the upper airway for neurologic manifestations, sometimes lumbar punctures, and of course many different varieties of obtaining tissue for biopsy. So some patients follow the textbook. This is a patient that I very recently treated for this flare, which you can see perfectly. The IgG4, which is the top level, starts to go up. The complements become undetectable, as you can see with the green line, which doesn't connect to that question mark, which means below detection. And then the bottom green line, the IgE, starts to go up as well. So this patient had done these labs before our visit, but I didn't wait for the visit. I called him and asked him what was going on, and basically which arm did he want the IV in for the rituximab. And so we treated him very quickly, and he's doing well. But many patients don't follow the textbook. They follow maybe one or two components or maybe none. And so we have to be aware of that. Again, principles thinking about different regions of the body. If you have disease that's really limited to the lacrimal and salivary glands, that can usually be followed through examination and patient symptoms. Sometimes we want to be a little more objective and quantitative, and imaging can allow us to do that. If that's the only manifestation, at first presentation, I would always still recommend getting imaging of the body to ensure that there aren't other silent manifestations that haven't been identified. For the pancreas, patients may have weight loss, worsening diabetes from dysfunction of the organ, or sometimes pain from pancreatitis, but many are asymptomatic. In this case, imaging plays a very important role in monitoring disease activity and is typically done at a regular interval. And so for some patients, some of the pancreas-specific labs, such as lipase, can be helpful as well. The aorta is often a silent manifestation. There are sometimes symptoms, but often not until there's a more serious complication like an aneurysm or dissection. Many centers, including ours, have specific protocols now with CT or MRI that allow you to really visualize the vessel wall well and understand if there's more thickening or inflammation. I have patients from all over. One patient from Winnemucca, Nevada, it's a 10-hour drive, who, by the way, came every month for a year for a trial. But he also, when we need imaging like this, he comes to Stanford to do it because there tend to be differences compared to Simon Med or whatever, radiology outpost is in the community. So for something more sophisticated, I would recommend, if you are able to get to a larger center. And PET scan's often important for this manifestation as well. I mentioned this first symptom because last week I had a patient email me to say that she had noted her urine was extra bubbly. And I kind of discounted it a bit. She had initially presented with pancreas disease and kidney disease, and she noted that those symptoms were present then, but we had treated her with rituximab about 16 months ago, but 5 weeks prior she had an MRI that showed nothing going on in the pancreas. It also visualized the kidneys, which looked fine. So I sort of doubted that this was anything, but I had her do labs, and her urine protein came back with 2 grams of protein. Normal is around 100 milligrams, and that was how she had presented initially. And so I actually called her last night before dinner, and of course I told her I never doubted her. And so we're getting some additional tests and probably treatment soon. So that's an interesting case where the 2 different organs, the pancreas is still inactive, but it appears that the kidney disease is active again. So symptoms like that may seem trivial, but those are important things to talk to your doctor about. Things that you noticed at your presentation that may not seem related, if they come back, I would at least mention them. And for this disease, when there's retroperitoneal fibrosis, imaging, sometimes PET scan is important. And for these more complicated cases, there's so much going on. Some may be symptomatic, some may not. You really need full assessments at regular intervals to know what's going on. So a couple sort of examples. This is a patient of mine who has known pancreas disease. He was treated initially with rituximab, never had an elevated IgG4 serum level, even at presentation, but very clear pathology and imaging, and we've been following him. I still continue to get IgG4 levels even though it was normal. He had kind of a routine surveillance MRI in February of 2024 that showed just slight increase in some narrowing in the bile ducts, and also just, I love these terms, increased conspicuity. So just, little suspicion there that something's going on. So I saw him 2 months later, totally asymptomatic, and we noted this slight upward trend in labs, even though they were still normal. But it was enough to say, let's repeat the MRI in 4 months from the last, so much sooner than I would typically do. And this was the inflection point actually where we decided to do that. The blue is the normal range, and it sort of spoils it here, but actually you can see that this patient for the first time ever went into the abnormal range, and he had never been abnormal. And this is why we're still learning, and I think this is a case where continuing to check the IgG4 was helpful. And so even this little trend, also in IgE, also in the ESR, which is not something I typically think of as an important marker, but often will be elevated when the immunoglobulins are high. Those all sort of led us to get that MRI. This was the February MRI, and just 4 months later, there was significant mass at the head that was causing narrowing and downstream dilatation. So you can see, it went from 3.6 millimeters to 8 millimeters. And on the T1, you can see a pretty significant change in the edema or swelling of the pancreas. We had not been trending lipase for this patient because it had also not been helpful, but we did it eventually, and it was quite high. So again, something we learned. And you can see the next value is 14 days later. So these were the sort of pre and post B-cell depletion, and things improved quite quickly. The next patient is someone with a very multisystemic disease. You can read it there, almost every organ. This requires a lot of different imaging tests, so there's not one test that can really capture everything. That gated CTA, chest, abdomen, pelvis, can do a lot, including the heart and the lungs, and quite a bit in the abdomen, but for the pituitary, you need brain imaging and things like that. So this patient, some things were symptomatic, some were asymptomatic. The gated CTA really showed that things were stable or improving, except for one thing, and it was this essentially consolidation or mass in the lungs, which had increased quite significantly, even though everything else had improved. And of note, this is something, we had plenty of lung imaging, and there was never anything in the lung, and this had appeared despite all of our treatment and monitoring. And so this was a situation where a repeat biopsy was necessary. And we did biopsy that when it first appeared, and it was sort of classic pathology for IgG4-related disease. So this is, again, to show that, typically when the disease flares, a lot of organs flare simultaneously, but there are cases like this where a lot of things are looking in remission and something new appears, or something, one thing in particular is changing and prompting treatment. And this patient generally follows the textbook quite well. These are all sort of flares in treatment, IgG4 and IgE. You can see in the IgG4, the blue range is at the bottom. This patient's never been normal, so that's okay. Don't worry if many patients are in remission with still very elevated IgG4, but the trend is what's more important. In this case, the eosinophils also are elevated and improve with treatment, and the C3 and C4 are totally normal. It never had an abnormality in complement. So again, this just sort of points out not every marker trends with disease for every patient. Each patient is really unique. And the third patient is a patient with known aortitis, initially diagnosed in 2013, and had rituximab, had been in remission for 5 years. Generally think of this as being relatively asymptomatic, but she complained of worsening shortness of breath, fatigue, some right-sided chest pain, and some hoarse speech. I saw her in clinic. It was notable but sort of mild, and I again sort of doubted that the hoarse speech was related. I told her we would sort of table that, maybe see ENT later, but work up the aorta first. We did labs at that visit, and her IgG4 and IgE both were spiking, and her PET scan showed this area here, which is the ascending aorta, suddenly was very metabolically active, and this was seen throughout many segments of the aorta. Interestingly, I would have never ordered a PET scan to look at the larynx or voice box, but of course it was detected on this PET scan, and it was incredibly metabolically active. And so again, I told her, of course, I never doubted that this was from the IgG4-related disease. And we treated it, and it completely, this was something where I initially thought maybe we should send to ENT and have them look, maybe biopsy, but we couldn't wait to treat with that aorta. And so we started treatment, and this completely resolved, and clearly was part of the IgG4-related disease. After treatment, it's also very important to monitor the response to sort of establish what a treated baseline looks like, so that you know what to look for in change down the road. So this is an example of a patient with diffusely enlarged swollen pancreas, and I hope you can appreciate that it has sort of resolved to normal size here. Sometimes with the bile ducts, again, we do procedures, or we don't, but the gastroenterologists do, called ERCP. You can see in the distal 2/3 of the common bile duct, there's a stricture, that narrowing, where the dye has a hard time passing, and then you can see in follow-up this was just after a few weeks of steroids, quite a bit of improvement in that narrowing. So that's another way to sort of monitor. This is a patient of mine who clearly has very active disease in the lacrimal glands. The right submandibular gland had been removed surgically before I saw him as part of the diagnosis, but the left submandibular gland is enlarged, and you can see, I almost got a smile out of him, but he dramatically improved, like a new man after treatment. So this is something that you don't need imaging for this. I mean, you can see this in clinic, and the patient can tell you. And if you're really nice and friends with the radiologist, sometimes they'll make these really nice 3D volumetric renderings for you. So you can see on MRI really enlarged lacrimal, parotid, submandibular glands, and you don't even need to quantify this, although they can do that now, to see pretty dramatic improvement. And if you're really nice to the nuclear med people, they'll make these, this is called a maximal intensity projection. Again, I told you the brain is always very metabolically active, so it's black. Normally the lacrimal, parotid, and submandibular shouldn't be, and after treatment you can see they're barely visible. So these are not necessary tests by any means. This was actually part of a research study that we did, but it's nice to know that this is how the change looks. I mentioned I have a few patients who have had skin involvement. This is a patient with known multisystem IgG4-related disease who suddenly developed this raised lesion on the cheek, which we biopsied with classic pathology, and after treatment with B-cell depletion, it essentially resolved with a little residual redness. So this is an example of what I mentioned with the gated scan that allows you to see the coronary arteries around the heart. If I had an hour to give this talk, I would orient you to this image, but it's not worth the time. So just trust me that that is the left circumflex coronary artery, which is supplying blood to your heart. If that's obstructed, you'll have a heart attack. The light gray portion is the blood traveling through the artery. All the dark gray sort of haziness around it should not be there. That's totally abnormal. That's IgG4-related disease, and basically nothing else in the world causes that. When that happens, it can cause inflammation to the wall, which leads to aneurysms or dilations. It can also extrinsically compress the artery and cause a blockage. So we've had patients who were told they had typical coronary artery disease, atherosclerosis, because they had a blockage, they got a stent. And later, when we've done these images, we've seen that the stent is right in the middle of this exact pathology. So it was clear that it was from this. But when they're doing their catheterization and shooting dye through the vessels, they have no way of knowing why it's narrowed. You need this sort of imaging looking at the outside. And the other point I would make with this is this was the follow-up scan after treatment. This is actually the patient with the really pronounced lacrimal and submandibular gland. He also has this manifestation. And what you'll see here is it doesn't really look any different. If anything, to me, it looks worse, but the radiologist promised me it's the same. And I think the point here is that sometimes we're just looking for stability. You don't necessarily need to see improvement. Sometimes you will never get improvement. What we want is for it not to get worse, and not to cause aneurysms or blockages. So if you see results on your scan that just say unchanged or stable, that's not necessarily a bad thing. That's often a good thing. We just need to make sure we're on top of it so that it's not getting worse. And this is the same patient. So with that same one study, we can also see the fact that this patient has, so this white thing in the middle is the aorta. It's in the pelvis, right about to split into the iliac arteries to go into the legs. All that light gray around it is abnormal. That's IgG4-related disease. And you can see in the follow-up scan, it's much improved. In this same patient, we can also see that there's something infiltrating the kidney. The white thing is the kidney, and the gray stuff is IgG4-related disease infiltrating into the hilum of the kidney. And we can see a nice, it's much cleaner here. This is what we love to see. It's there, but it's like it got a nice little haircut. It's all cleaned up. And we want to prevent it from looking shaggy again. And those are technical radiology terms you don't need to worry about. And this is a patient of mine, a 50-year-old mariachi singer who suddenly noticed he was having trouble singing. He saw ENT. They thought it was sort of like barotrauma, something from all the singing and damage, but they saw this, what we call pedunculated mass, kind of hanging off the vocal cord, and they sampled it, and it was classic pathology for IgG4-related disease. We treated him, and he's back to singing full strength. And now I have access to free services of a mariachi band, and I'm trying to figure out how to incorporate that into my toddler's upcoming Spider-Man themed birthday. But we'll see how that goes. And these are not my patients; these are just from the literature. There's something called a thoracic paravertebral mass, and you can see that improves with therapy. It doesn't resolve. Once again, we're just looking for some improvement in stability. And this is also from the literature, a case of sclerosing mesenteritis. All this haziness is fibrosis and inflammation. And this patient actually had a very dramatic response to therapy with resolution. Typically, in my experience, these are very hard to treat. And so there's a caveat. There's some nuance to this depending on how you all might be treated. That really dictates the monitoring a bit. So I had shown this yesterday. This is sort of my paradigm for treatment. I generally tend towards option 4, which is the B-cell depletion. Regardless, after you treat, you're sort of monitoring, there's some level of remission, and then you can either watch off all treatment, and when you see signs of disease come back, you can treat again. There are also people who take the approach of just regular maintenance, and like inebilizumab was studied in the Mitigate trial, saying we're going to treat you every 6 months. So if we drill down on the top one, with watchful waiting, that's really a reactive approach, and it requires real vigilance. We want to make sure we catch the disease coming back right away before there's damage and we get treatment started. The benefit is it minimizes exposure to immunosuppression. The sort of scheduled treatment approach is proactive. It's saying we're just going to treat you every 6 months. If you do that, the monitoring demands really go down. It's highly unlikely something is going to come back if you're treating every 6 months with inebilizumab, for instance. But you may receive excess immunosuppression unnecessarily. So these concepts are things that, as a field, we're still trying to sort of reconcile and unify. But at the end of the day, there won't be one right answer for every patient. Every patient is unique, and we will tailor it as such. So to conclude, a little levity and pardon the language, but this was the first patient with IgG4 I ever saw as a resident at MGH when I was working with John. This was my primary clinic, and he messaged me on a Thursday at 6:41. I was headed to liver rounds, which is what the residents call meeting at a bar for a social hour every Thursday. And the message was, I think you've all read it, but hi doctor, I saw my blood results came back with an IgG4 of 400. I also saw an abnormal ECG result. This weekend, should I spread my legs, bend over, and kiss my butt goodbye? Your response will be greatly appreciated. And what I told him is the exact same thing I'm telling you now, which is it really depends. First of all, I would never say kiss your butt goodbye, but whether the disease is active, it really depends on the context. So if this was a patient who a month ago had an IgG4 of 1,000 and it's now 400 and they have no symptoms, this is not something I'm worried about. But if it was 100 and it suddenly jumped to 400, and whether or not they have symptoms, I'm probably going to investigate. So it's sort of the same thing I told him many years ago. And I come back to this, which is that really the assessment is quite comprehensive. So these are the final slides. So again, it's a very heterogeneous disease. There's a broad spectrum of manifestations. We really need the full assessment to determine what's going on. I gave an example of how being vigilant as a patient and reporting symptoms, even if they seem trivial, is really critical. And it's nice to know now that with appropriate treatment, most manifestations will improve or at least remain stable and not cause harm. And so with that, I just say thanks to all our patients, to former mentors and colleagues, and to Arzu and John, and of course our family who allow us to be away and be here with you all. So thanks.
There's a question over here. Kennedy.
So I heard pretty consistently this weekend that there's either a lack of rheumatologists or PCPs and other specialists that don't know about IgG4. And we do have a lot of patients that live in rural parts of the state or far away, like 10 hours. And since early detection of flare is really important, I guess any studies going on already or interest of using digital devices for earlier detection of flares?
Yeah, that's interesting. I'm not aware of like wearables or digital devices. I think with the advent of telehealth, before COVID in our clinic, it was 100% in person. Then overnight we switched to virtual, and of course now we're able to do both. And so that's enabled me to see patients from literally the entire West Coast. Technically they are supposed to drive into the state of California to join the visit, but I of course don't care where they are if they don't tell me. So, what I tend to do is co-manage with someone locally, so they have someone on the ground that they can see, and then I might see them every 6 months or even once a year, just to provide some input on what's going on and kind of help oversee the case. So, but of course there's a limited number of us that can do that, but I think right now we have a few regions sort of covered, and we really just need more expertise. To your question, I think it'd be great to look into digital monitoring. I would say that's been a challenge in other diseases that are much better studied and have a lot more data. They've tried to do that in RA and lupus, and I haven't seen great data to support it, but I'm all for kind of innovation. So.
Matt, great talk. Thank you. I had a question about your patient with the frothy urine. Mm-hmm. That usually indicates a glomerular lesion. Had she had a kidney biopsy, and did she have glomerulonephritis as opposed to the usual, more common tubulointerstitial disease?
Right. When she's developed the pancreas disease, all of a sudden her creatinine jumped to somewhere between 2 or 3. She's a skinny younger woman, and the nephrologist from the outside just said this must be TIN related to the IgG4 lady. She did have some proteinuria then too, but the treatment was started so quickly for the pancreas, and then everything got better, and so it was never further investigated. So that's why I'm not jumping to treat immediately right now. I think it warrants some further investigation, especially with the pancreas looking totally normal. Yeah. She saw Walter Park actually 2 days ago, and he ordered some additional tests, so we'll have to see.
Thanks.
Thanks, Anton. So I'm just thinking of all of the poor people out there who don't go to the right doctor. They go to one doctor who addresses one symptom. They go to a kidney doctor, or they go to a lung doctor or a heart doctor. And the doctors don't ask the right questions to get the entire picture out of them. Mm-hmm. And that was our journey. And I just feel so bad for the other people out there who are experiencing this, and wish there was some way to popularize IgG4 to help other people.
I think we're seeing that coming. I think with having a FDA-approved drug has helped. And Amgen has done a lot of work to boost education. I think it will take patients actually also being educated and becoming advocates and knowing more about the disease. We also hope that the physicians will too, of course, but it's super important for the patients to be advocates, and we're hoping as we're developing these educational materials that will be the case. I also think John mentioned that the foundation is going to be supporting the development of some guidelines, and that will be critically important for, so that kind of all of our collective expertise can be put into that, and then that will be made available to the community folks who really depend on that type of thing to know how to monitor and manage and treat this disease.
When I came here, I thought I had cataracts. I couldn't see anything. Thanks to this incredible conference, my cataract has been removed. And for this, I would like to thank all the people who are involved, and of course, the big cheese. Thank you again, and may God bless you.
Oh, thank you.
Hi, Dr. Baker. Just wanted to say thank you for bringing up a few of the slides, in particular the one that Dr. Stone mentioned too, relating to the frothy urine. That's something that's been like a mystery, because I have exactly that same symptom over the period of time. It comes and goes, but asking my urologist gets just like blank stares, and they seemingly know nothing about that aspect of the urine analysis. So it's obviously not something that's as uncommon as you may think. Thank you for bringing that up as to that.
Yeah, what I would say is, something like that always should warrant investigation. It doesn't necessarily always mean that it's directly related or that there's a problem. It is one of those things we hear from time to time, and it doesn't end up panning out to be really a relevant clinical sign of the disease, but it certainly warrants investigation. And I've learned over time that these little things really matter, and that you should really always take it seriously and look into it. Thanks.